respected judges, team Umme, and all my friends. Should I start now? A very good afternoon to the respected judges, team Umme, and all my friends. I'm going to present a case of HIV-TB co-infection. I'm Umme Sufiyya from GSL MC Rajahmundry. As we all know, several infections are associated with AIDS, tuberculosis being one of them, is not just a very well-known infection, but despite of all the advances in its treatment regimes and awareness, still remains a clinical challenge, causing 9,40,000 deaths and 3,20,000 deaths in non-HIV and HIV patients respectively in 2012, according to WHO Global Report. Here is the case. A 30-year-old female came with chief complaints of cough and fever since 3 months and breathlessness since a month. Present illness. Patient was apparently free of respiratory complaints before 3 months, till she developed cough that was productive, mucopurulent, yellowish, non-foul smelling, and minimal. Fever was insidious in onset, low-grade evening rise of temperature. Breathlessness was grade 2 according to Medical Research Council classification and grade 2A according to Sherwood-Jones classification. The above symptoms were associated with loss of appetite and weight. There was no previous history of tuberculosis infection. However, she had a history of contact with an established case of TB. There was no history of bronchial asthma, COPD, allergies, not a known diabetic or hypertensive. Her age of menarche was 14 years. Cycle was regular for 3 days, not associated with clots. Hysterectomy was done, so now infertile. Obstetrics, G3 and A3, past medical and surgical history. There was no relevant use of long-term medications, and hysterectomy was done in 2006. Family. Her husband was diagnosed as seropositive for HIV and sputum smear positive for AFB. Rest were having good health. She was a non-smoker, non-alcoholic, takes mixed diet, living conditions unhygienic. Married since 18 years and has no children. She worked in fireworks shop, then medical, now a housewife due to ill health. On general examination, the patient was conscious and coherent, though sometimes incomparable. Poorly built and malnourished, pallor was present, cyanosis, clubbing, edema, jaundice, lymphadenopathy, puffiness absent. Her height 125 centimeters, weight 125, and vitals were such on examination. Systemic examination of thorax, inspection, shape of chest was flat and bilaterally symmetric, chest movements were reduced on right side. There was no involvement of axillary muscles, intercostal recession, and engorged veins or scar marks. On palpation, trachea was slightly towards right, chest movements reduced on right side, apex beat was on left side, fifth intercostal space. Vocal tactile fermenters present. Direct percussion was resonant over the clavicle and indirect dull note on right side upper lobe. On auscultation, right supraclavicular and suprascapular bronchial breath sounds heard. CVS, CNS, and abdomen were normal. Differential diagnosis was right upper lobe fibrosis due to infections. That is, investigations, radiological examination showed like opacities on the right side upper lobe and slight shift of trachea towards the right, suggesting fibrosis. Biochemical analysis showed decrease in sodium levels. Clinical pathology showed she was anemic, and sputum smear positive for AFB, seropositive for HIV. Final diagnosis was then made as upper right lobe fibrosis, possibly due to tuberculosis, which might be due to immune compromised state of the individual because of HIV infection. This was the clinical course of the patient and the treatment. Day 1, 2, and 3. The complaints were treated. On day 4, ATT category 1 was started. On day 5, around 8 a.m. in the morning, she developed an episode of seizures which were controlled by administering lorazepam. And on 6th day, she was stabilized, hence ATT was continued. Prognosis was not very good in this case. Effective screening before marriage would have helped prevent HIV infection, and early treatment would have led to a better prognosis. Now let us go through some questions, starting from the second one. The targets to bring down the occurrence of new cases is screen and treat HIV patients, immigrants, and medical staff. The necessary steps that we can take to prevent and spread of emergence of MDR, XDR, TB is efficient use of DOTS plus, and Stop TB programs by WHO and RNDCP by India. The treatment, according to the treatment duration of the infection and the co-infections, the respective treatment should be started as soon as possible and never use a single drug. As medical students, what can we do? we can actually counsel the patient apart from taking the cases about the disease, the risk factors, and how to keep oneself safe. And to keep oneself safe, they should cut off like unhygienic practices, addictions, and get proper treatment, a full-fledged treatment. And what one should do to protect oneself and get cured with better results? Try to follow the regimens and take them properly. And thank you.
Usually fibrocavitary lesions are common in the apical lesion, okay, apical lobe of the lung. So any condition, where the base of the lung containing tubercular cavity or tubercular lesions.
Ma'am?
Do you want ma'am to repeat the question?
Yes.
See, fibrocavitary lesions or tuberculosis common among the apical lobe, okay. So any condition where you get a tuberculosis infection in the lower lung, also lower lobe of the lung or base of the lung with fibrocavitary lesions.
Commonly TB occurs in apical lobe of the lungs. Do you know any condition wherein you have
Sorry?
the lower lobes involved?
Pneumonia.
TB involvement, tubercular involvement, not only pneumonia, tubercular involvement, as you said, associated with HIV is other presentation of tuberculosis. Other than apical lobe, lower lobe also involved in HIV presentation, HIV associated with tuberculosis.
HIV, TB, apical lobe, you have fibrocavitary lesion. In the lower lobe, do you have any other type of lesion?
In the lower lobe, we have.
What is the CD4 counts in this patient? Counts, CD4 counts. Viral load, CD4 counts.
CD4 count should be kind of less than 200, 150. Sir.
CD4 counts.
CD4 count should be less than 200, 150.
In this patient.
This patient, the CD4 count was given, sir, but I did not have enough time to update. The reports will be coming maybe today or tomorrow, sir. I'm really sorry for that.
Okay. Any treatment? Is there any treatment difference between a normal person and a HIV person?
Treatment difference in a normal person and an HIV person having TB.
It depends on the weight. As this patient is having just 25 kilos of weight, a pediatric dose should be given to prevent complications.
Can you be closer to the mic?
Yeah.
And
Repeat the answer.
It depends on the weight of the person as well. As this person was 25 kgs, so a pediatric dose should be given to avoid complication of drug interactions.
Treatment schedule is related with age dependent, do you think?
What is the treatment you want to give in an HIV patient compared to normal patient?
Tuberculosis along with ART treatment, but here we did not give ART because she was already anemic.
regarding a TB drugs.
PC13 and PC14 were given to this patient, sir.
Okay, leave it. Okay.
Any questions from the audience? Okay. Yeah, we should proceed.
Thank you.